Welcome to the Sustainable Clinical Medicine podcast. I am your host, Sarah Smith. I am a practicing rural family physician and the charting coach. This is the podcast for physicians and advanced practice providers who are ready to step back from the busyness of their clinical day to share ideas, question everything, and redesign their clinical day. We are redesigning clinical medicine to create sustainable clinical days and create time for our lives outside of medicine. Join us for discussions with world experts who are helping design sustainable models of clinical medicine and the physicians or clinicians who have discovered or designed sustainable models of clinical medicine for themselves. Hello, everybody, and welcome back. Today, we have special guest, Dr. Noah Crampton, who is one of the Canadian physicians, but he's also very curiously, and we're going to find out all about this story, invented for us in real-time scribing. So we are very interested to hear all about this, and I'm going to let you introduce yourself to us. Take it away.
Well, thank you so much, Sarah, for having me. Yes, so I'm a family physician at the Toronto Western Family Health Team, and I am now leading the commercialization of some of my research that I've done of a project called AutoScribe, which is an AI-based scribe technology. So what you can imagine is there's a microphone attached to the computer in the exam room, and as the doctor and patient are talking, in real time, the AI is processing the conversation and predicting a medical note based on the knowledge that it has. So it's really exciting to be able to do that because the accuracy has jumped to an extraordinary amount in the last few months.
Yeah, that's really, really interesting. What I find even more interesting is a family physician doing research. And so I pause for a moment because I know how busy we are as family physicians. Not all of, obviously, the audience are family doctors, but we hear all the time how busy family doctors are, and there isn't any time. And the fact that you found time to do research. So tell us about that. How did we get there?
Yeah, no, so like I'm sort of made my own path for my career journey because there was not much to model after, as you can imagine. I did my residency between 2014 and 2016, family medicine at the University of Toronto at the Sunnybrook site. And I always knew that there was this odd discrepancy between the power of our tools in our private consumer lives and the difference in our EMR, experience as physicians, that it was just it was always a decade behind in terms of user experience and functionality. And I thought that, we're dealing with patients, we're dealing with human lives here. You would think that the most important thinkers in user experience and design would be putting that healthcare first and foremost over the consumer world. So I thought there was a disconnect going on somewhere in the system, in how we're training our trainees. So what I decided to do, with the support of some mentors that I sought out, was to actually go for PGY 3 and 4 in the Clinician Scholar program, which is not too many people go for that extra training as researchers. But basically the ministry will fund you to pursue a master's. And I decided to pursue a master's in health informatics because I wanted to solve this problem, which was, the digital health experience of family doctors and how to improve it.
I love this. I love that somebody thought about the fact that my EMR can't tell me what patients are allergic to, and that what I'm prescribing might conflict with that. I like the fact that perhaps somebody's thinking about the fact that I do not have autocorrect when it comes to just regular old spelling mistakes in my letters still. And you're right. We are not setting up EMRs to help physicians. That is not the intended user of an EMR. Yeah. Turns out the person using it is not who it was designed for. Most of the time, it was designed for information in and information out, if we're lucky.
Exactly. Yeah. So we've had to sort of make do with what was ended up being disseminated across the system.
Yes.
There's all these workarounds, obviously, that I'm sure you're the expert of the workaround.
That's right. Nuancing these EMRs so that we have some semblance of done about our day. Exactly. Yeah, the workarounds, which can take years to get finessed for each of the EMRs. Okay, so what was it about? So you were already in family medicine stream. Is that correct? When you decided that this is not a great model that I'm in right now?
Yeah, so I thought, look, I have to, obviously, I love medicine. I went into medicine for a reason. I want to be a family doctor, but I also like the idea of the hat switching. And I knew that by pursuing the clinician scholar program, I was almost certainly going to get a funded research position at one of the academic sites. So I am now, as you know, Toronto Western. I'm part of the University of Toronto faculty. And so in terms of whether I'm the most, financially compensated family doctor in the world, probably not, but I have a lot of meaningful work, right? I'm working on very innovative tools that I feel like will have, hopefully large impact on the system, and my fellow colleague family doctors will benefit from them.
Yeah, yeah. What were you noticing about your clinical day that really made you pursue this interest from your own experience or from the experience of watching others within it?
Yeah, so basically, we go into medicine because we just like human relationships and also the ability to provide healing care, right? We want to be there for our patients, use our knowledge, our empathic connection with them to, tailor evidence to their unique experience. So I felt constrained by that because there was so much cognitive load focused on the screen as I'm interacting with patients, right? It's just, you can't be the full potential of a clinician when that is your context, that your workflow is, right? So in residency, I said, this is, as I said, this is unacceptable. Nobody's going to address this. I am. So I'm sort of an initiative taker that way. And basically all my colleagues validate that. But for them, it's like they feel very much stuck in it. And this is the system they're in. There's little control over trying to change it. So they just have to figure it out, get through day by day. So yeah, I decided to think about, okay. And at the same time, I came into my early staff positioning at the same time that AI was really taking off, right? In all the other domains of life. Toronto was actually the birthplace of some of these neural networks that are powering this incredible technology. So I felt like I was really at a great nexus point of clinical thinking that could be progressive, as well as trying to, okay, how can we think outside the box and bring AI into clinical workflow in a way that is helpful to clinicians rather than scary or suspicious or
Replacing us.
Replacing. Yeah.
I agree. I think that piece about AI is coming and you'll be without a job. And we're like, you don't understand what my brain does. Like you said before, individualizing that evidence-based medicine, contextualizing it for the patient in front of us, and really deciding on a plan that's going to work best for them, knowing what we know about our patients. This is the foundational piece of what we love to do in medicine, especially in family medicine, I guess, where we know the family, we know the context of this patient, we've had this continuity of care, we've got all of these paths that lead to a good outcome for our patients, and which one should we put them on is the piece of medicine which becomes fun, right?
Yeah, and the way I'm viewing AI is we have to have us clinician leaders with support from obviously patients with lived experience be at the table of how we introduce AI in a very meaningful quality improvement kind of modality rather than some major corporate with a strong profit motive just forcing its way in, and then we're going to deal with EMR experience time, the second episode, basically.
Mm.
And that my role that I'm hoping to cultivate is, pause and let's do this in a thoughtful way where everyone agrees we're doing this properly.
Yeah. So now you kind of take this idea and you then have to research. So what do you have to research? What is the kind of steps towards this idea that you have thought of?
Yeah, so given all of what I've just said, I'm actually not a computer programmer myself. What I learned in the Masters of Health Informatics is actually the concepts of computer engineering software, how programs work. I understand the vocabulary. Like I can be very much at interdisciplinary discussions between computer engineers and clinical medicine. Like I'm right at that sweet spot.
Yeah.
And that is a unique, very uncommon skill set, I would say. So I don't need to program the software myself, but I need to be able to give clear direction as to what we experience as clinicians and how this will work for us in our workflow. So AI scribing, I've been working on it quietly since before the pandemic, because we had the foresight to see, okay, what AI can do in 2019, 2018, 2019. It was extremely well, but maybe it wasn't mature enough to really start to show that it can, be reliably accurate all the time. But we had to lay the foundation to get like an application that would work well in physicians' workflow going, and obviously the privacy, security, legal, all that stuff also takes a lot of effort and thoughtfulness about how to do. So during the pandemic, while I was helping out, clinically, I was working on that with my co-founders who are software engineers. A lot of hand-holding for them to explain to them, no, it can't be this way, it has to be this way. And we finally got the resulting product where it's integrated into a couple of EMRs now, so it's really exciting.
That is exciting. What do you think your patients thought of all this in 2019 when you're doing this pilot project of these encounters where you're being the doctor, but you're also consenting them for this AI listening in? How did that go?
Yeah, so I'd say 2019, we were still in the simulation phase. We were not bringing this into real clinics. We actually published a simulation study. It was in its immature form at that point. Because, both doctors and clinicians in those simulation studies felt that they could see the value, especially the direct human connection that can occur. And the reduction of clinical charting effort, because it's mostly done for them. But the accuracy of the outputs at the time were just, there was too much editing required, and it wasn't providing direct value that it's supposed to. Now we've got these things called large language models based on transformers, which are this exciting new natural language processing tool that we have in artificial intelligence. That really started to become like super accurate within the last year. So we had a whole pipeline set up, and it was just like the missing piece of the puzzle to make it everything reliably accurate. And the timing couldn't be more perfect that it came out when it did. And now end to end, it's really quite a mesmerizing experience.
Great. So tell us about the clinical day now. How does this look different?
So I'll talk about, what our current tool is, and maybe we can get into the vision of what I'm hoping this will be the foundational layer for future added value, features. But in its current form, basically, the way we're recommending it is that we have a long form consent for patients, because this is new to have audio recording in the exam encounter, right? Like, some patients will take their cell phone out and record a visit just for their after the visit, but a lot of doctors don't like that. So it's some of the audio recordings have been happening, but mostly it really hasn't. And obviously we talk about very sensitive matters in a clinical encounter. So we do recommend, and we prepared a template for a long form consent for first ever use of AutoScribe by a patient, that they read it, and that can be scanned in AutoScribe and saved indefinitely. So once that's done and a patient is in the room, the doctor, in our EMR integrated versions, there's a button in their EMR. They just click AutoScribe, it launches, and they have to then click the microphone button to record they'll again ask to be reconfirm patient consent. This is a big thing, and I'm not going to go deeper into that. There's a little prompt, reconfirm patient consent, and then you just talk to your patient, and it requires the entire conversation. You look directly in their eye. You can quickly look at the screen to make sure that you can see the transcript being generated. You can see the note being generated, just to feel reassured that that's occurring. You can continue to engage directly without typing anything. And basically within a couple minutes of the visit ended, you press end encounter on the application, you'll get a final note. And rather than me typing during the encounter furiously to remember everything and hopefully not forgetting anything, and then having to come back at the end of the day to tidy up whatever scribbled notes I made, it's like 95% accurate on average, my notes. So I have to make small tweaks here and there. It takes me a couple minutes. I submit to the progress note section of the EMR, and I move on, and that's it.
Nice. Okay, so this is the difference before and after. So before, scribbling notes in the encounter, losing eye contact with patient, cognitive load of the screen in front of you. Then finishing up those notes at the end of the day. So what in real time do you think this is costing you differently in terms of the day-to-day time in the charting piece?
Yeah, and like we've studied this. We did pilots, Corthaleg's family health team, etc., where 50% of time is being saved on charting.
What?
Yeah, which is like a huge amount. If you think about it, that frees up like 3 hours a week of whatever you want to do with that 3 hours. It's some doctors want to see more patients, make more money, fine. Other doctors want to go home, be with their family, feel rejuvenated from their personal time and come back and tackle the next day with more gusto, right? So that's exactly what our objective has been, and it's really impactful once they get the hang of it, right? There's a little bit of a learning curve, a little bit of a change management piece. Happy to get into that, but once they get the hang of it, it's really exciting.
Yeah. So tell us because any new unfamiliar piece about our EMR is clunky and unfamiliar. It causes a lot of distress. There's new, even we now want you to record if patients are smokers or not, can just feel like the straw that broke the camel's back. I remember the project is like, we got a new project, and we just all,
data entry, yeah.
Our brains went to very bad places and our attitudes became very unhappy. All right, but this is an opportunity to potentially save us or create time. Save us time or create time. Love it. And then there's how long does this take to kind of get used to, and how easy is it to implement? So yeah, tell us more. Get us into that corner.
Yeah, so there's really like it's pretty intuitive user interface. Like that's why it's good that me and my clinical colleagues were leading the design of it, because it's for family physicians. It makes sense as to how it's used. There is a bit of setup depending on which EMR you are using to enable the integration, and there is the opportunity for our company. Now I'm speaking specifically about how our company functions to help with the learning and change management, is that we do provide PDFs and videos of all the first sign up, how to use, frequently asked questions, and so you can do that on your own time. But also, we're always here to support in terms of our customer service team for you to ask specific questions, or if something doesn't seem like it does in the walkthrough documents we provided. So we really want to facilitate that piece, because we know any change management for anything in medicine is something that gets us a little bit nerve-wracked. But the payoff at the end of that, couple weeks, which is why we offer a 1 month free trial, by the way. We offer a 1 month free trial because usually that 1 to 2 weeks to try and just make sure you're adapting your workflow, because it's a new habit, and new habits can take time to develop. That we really want you to spend that first 2 weeks getting that habit going, and then the last 2 weeks is actually, now I'm seeing the benefit. My time liberated in those last 2 weeks of the free trial is I have so much more time with my family, or I want to make more money, whatever the motivator is. That's when we're seeing that conversion from the free trial to the paid ongoing, sustained client because they feel that we provided them that support during that change management.
Yeah. So it cost-wise, in terms of the time cost to get it up and running, it sounds like it's pretty user-friendly, like you said. So it's an easier thing than we possibly are imagining in regards to getting it going. Okay, that's really good, because it's nice to know what is that, because again, it's just one more thing, right? So it's just getting into that space of, I know you guys are stressed in the thick of it. And especially for our, like I said, our family physicians, but other physicians as well. What about, so we're in Canada, so we have 2 languages in Canada. So tell us a bit about its ability to do more than English. Is that a possibility?
Great question. So I'll just emphasize that our core technology is taking the doctor-patient transcript and then transforming that into a medical note.
Mm-hmm.
Where we have challenges with other languages, including French, unfortunately, is recognizing medical terms in French. And so doing that speech to text component, which is actually, we're using off the shelf speech to text technology to get the transcript. And we've experimented with French, and when it's upstream like that, there's some inaccuracies. Then downstream, for our technology to work, the note becomes a little bit more inaccurate. So we are working on it. We were looking for actually the good partners in potentially in Quebec who can help us find a speech to text speech recognition model that has been very accurate for French medical terms, because we really want to make this work for our French colleagues.
I love that we're right on the cutting edge of this, you guys. Like, this is brand new, kind of tingly spine kind of AI stuff that could be actually helpful to physicians, and so new that we don't even have the French piece dialed in yet. Like,
yeah,
this is super cool. Like, a little nerdy, but that's okay. I'm not also
and
IT.
it's but it really illustrates some of that biases that can happen. And this is just one example that obviously we prefer English, and are we going to allow only our English colleagues to benefit from this while there's a delay for our French colleagues? It is just the nature of how these innovative technologies get fleshed out.
Yeah, I don't often need interpreters within my clinical practice. I know a lot of the physicians, nurse practitioners, physician assistants that I'm working with really do have many of their appointments they're using interpreter services, or even the Google Translator, right? So I have had to pull that out to be able to communicate on any level with some of my patients, especially through the COVID period. It was incredibly, you can see how it's so easy to have a barrier to health when you can't even communicate with your physician healthcare worker in front of you, and trying to reduce the barriers to health. And I can see how these types of things are going to be so incredibly important going forward.
Absolutely. And to our point, we've had some of our doctors, users, use it in the context of an interpreter in the visit, because English is still being conveyed back, right? And we're listening to everything.
Yeah.
So we can make a note still, even though there is another language present in the audio. Yeah, it's very fascinating.
Well, that's fun.
Yeah.
Okay, there we go. You guys who are talking to all of your peoples who are using interpreters, this could still be valid right now. And we're again on that cutting edge of this. So very interesting. Okay. What do you think would be, so when we're talking about, so where I have come from, let's back it up a little bit. I came into this saying, I can't change the system that's broken. I can't change the number of patients I see. Well, I can at a financial potentially disadvantage because I was fee for service. I can't change how many staff I have. I can't change the EMR we're using because that's going to be big investment in dollars, big investment in time. Everybody's going to be cranky for at least 3 months because we all have to get used to a new system, right? I can't change my world. So what is it about me that can be changed to be able to adapt to the facts of and math of my day, right? So that's the perspective that we do within that Charting Champions program, Smarter Charting program. We're saying, okay, within the system you work, within the environment that you work with, the EMI you have, with the patients you have, how can you get home with everything done? So that's always been, I can't change the systems for you. Let's help work on what we can adapt and change for you. And then you came along and said, no, I'm not, this is unacceptable. I'm not having it this way. I'm going to go and do the research and the hard work and get my team going, and we're going to create something new.
Correct. And it's like you either lead the change that you want, because the AI revolution is coming regardless. It's just what value system will be at the forefront of how that gets integrated into clinical medicine. Is it going to be large corporations like companies that shall not be named on this podcast, or is it going to be the patient-centered medical home and medical neighborhood, like CanMeds, all these things that have been drilled into us.
Yes.
We really have to make sure that AI, however it gets integrated into clinical care, be done in a way that is in alignment with those values. I'm we're way beyond the proof of concept stage, but I was actually most excited to get to the proof of concept stage, just so, look, it can be done in a way that is assistive to workflow and not feel like a burden. And then, as I said, I want to talk about the potential where this foundation of the Scribe technology, what else it can do going forward. We have to think about real-time decision support. What does that look like for family doctors, right? What does video of a visit look like, if even, right? Or auto form completion or billing prediction. There's so many directions where AI can be applied, but you really want to make sure that you're at the core of it, that the note that's being generated represents what you think clinically occurred, your reasoning, your judgment, what feedback you provide to the patient. And then from there, it should disseminate all these other opportunities. What I'm concerned about is some of these commercial vendors are putting the cart before the horse, and we're going to get, medications from some pharma-sponsored digital health company that are going to come right to the front of the list of our decision support, and we're going to click on that because it's the first one there, but maybe it's not the most evidence-based thing, right? Like, I'm just worried about how systems are going to be rolled out without a clinician and, patients, with lived experience being at the forefront.
Yeah, that's super important. Like even the thinking about how do we make clinical decisions in the room, and how do we now teach an AI to know how to create a note based on what they're hearing in the room and some of that decision making out loud that's happening in the room. If you're like paring back what you're doing within a consultation to be able to bring it forward to programmers and say, here, this is the sorts of things you need to think about when you're listening in on this information. Just that piece of it has got
complexity, right?
Smarts, right?
Yeah. The complexity it's really astounding. And we have to teach it to improve continuously. AI is not a stagnant thing. This is something that each edit the doctor makes retrains the AI models, changes the imputations of how much it weighs for different things. And then, we're going to end up with personalized AI assistants to each clinician and their workflow. That is where we're going. So how we get there is going to be a big question.
Yeah. When I often get the question of is a scribe helpful to me? Is a scribe the solution to this charting problem? And my hesitation is always about workflows and work lists, right? So if we have a scribe that's then creating for you these things that you have to look at the end of the day in order to finish notes, that's always my hesitation, right? It's now we're creating you another work list, another to-do item before you can go home. Like, of all the things you have to do before you go home, here's just another one. And so there's always that's not necessarily for most physicians, the answer. But why I brought Noah here for you today is because of this in real time piece. Like he's a physician who's thought about it from a physician's perspective. He's created it with you in mind, which is super fun, and our patients in mind. And 3, it's in real time. I'm like, that's always the cruncher for me when I'm helping.
Yeah, and like it's a wow moment when you experience it, because you'll press end encounter after you're done the visit with the patient, and you do have to wait sometimes 1 to 2 minutes for the AI to finish its thinking, and then you have a 90 to 95% accurate note. I mean, just imagine that notion, and then how you should read it, the note in its entirety, and make sure you edit it while all the information is fresh in your mind. But at least you don't have to type from scratch or dictate from scratch, and you don't have to type during the visit. With the cognitive load splits, there's just so many benefits.
Mm-hmm. I'm going to get questions now about things like our community health centers need to gather certain particulars about patient encounters while the patient's there, so they can tick the things that say what level of complexity. Do you think that there will be like that form completion, like you were saying? It's really just finding the things that were talked about in the encounter and ticking them off the list that they were talked about. I'm going to presume a computer can be taught that.
Absolutely. That's exactly the use case that makes the most sense for proving out what AI can do and all the time it can save, that we would normally be doing that, from scratch manually ourselves.
Yeah.
So I mean, part of the issue is actually a lot of these forms are still PDF based, or like we have to print and write them by hand, right? But for the ones that are digitized and can be linked to a tool like AutoScribe can predict it. Absolutely.
Yeah. So there we go. So if you've got those, even if you're working with those templates, it's still a possibility that this could be something that can be used and trained. So yay, so exciting. How can people find you if they're interested, especially if they, like you say, cutting edge, using some sort of French to English in their room?
Yeah, so first of all, please check out our website. We're actually having a big launch April 18th. Yeah, so it'll basically be automated signup. So you can sign up and get access to the app right away from the website starting April 18th. So our website is mutuohealth.com, MUTUO health.com. You can also email me, my first last name, noah.crampton @mutuohealth.com. I'm always happy to just, talk about different things with my fellow clinician colleagues, whether or not they want to even give AutoScribe a shot or just think about the potential for AI in our workflow. I'm doing a bunch of research. I just got a grant today, actually. Very excited, from the Temerity group to do predictive from doctors typing of a plan section of a note. So if you're going to start typing, I'm going to prescribe metformin 500 milligrams twice a day, it's going to auto prepare that in the EMR. It's really exciting stuff.
Ooh, nice. Yeah. Interesting. Yeah. Because of course we've got the note done, but we still have the prescription to write and the figure out who we're referring to. Exactly. And the, create the mammogram requisition and all the other pieces of the encounter that we've said yes to in the room that we still have responsibility for right now. So it's a watch this space, you guys.
It's an exciting space. Yeah.
If we have the occasional physician who's here, who's maybe also still student, doctor, resident, who's interested in doing these kind of master's programs, clinician, scholar, like tell us that experience for you was, obviously it's worthwhile. You've got at the other end a working product that is going to, like you say, hopefully change the world. What would you say to them?
Yeah, everybody's career path has to fit with, the constraints of their lives, right? So if you think that potentially a bit of sacrifice of, the upper range of financial potential in terms of the safety that medicine can provide at that level. Because obviously what I've done is a risky move. It's been risky in terms of the entrepreneurship journey I'm on, and trying to take a chance on the transform or the potential, even though it hasn't been realized yet, but we're on our way. I'm committing to a dream as a visionary. If you feel that in your gut that is the right move for you, then I really think you should start thinking about it as soon as possible, about the career trajectory at medical school student level, at the residency level, because there are so many mentors. I'm happy to be one of them. Again, you can email me for thinking about what are the pros and cons of different directions, not doing any graduate level degree versus doing a graduate level degree, or going directly into industry versus staying in academia, or going to the policy level. Like I've experienced all three of those. I know the pros and cons of each, and it's very good to become familiar with them, because where decision making occurs, what decisions that were happening at high up in the sky in the ivory tower, how they end up impacting us downstream at the practice level. So really, I do encourage, some self-reflection, some reading, lots of reading about what gets you going, what gets you excited, and then finding out the mentors who can help you on a path towards realizing your goal.
Love it. Thank you. I think that's not something that necessarily everybody thinks about. We certainly do hear a lot more about physicians having side gigs or passion projects or other sources of income, but maybe not having come out of medicine in that infancy piece. And hopefully you've just paused the financial benefit, right? Just taken one for the team for a few years, but you'll be able to catch up.
That's the hope. Yeah.
Exactly. Well, thank you so much. Anything we didn't cover that you'd like to talk about before we finish up?
No, this has been extremely, exciting discussion. I think the potential is really vast. It's almost like an exciting, but nerve-wracking state, because we want to be part of addressing the workflow challenges, the personal burnout issues that you are so, helpful in terms of addressing, and making sure that in 5 to 10 years from now, we're not resenting our AI just like we are our EMRs, right? So there's just there's a time window here that's very opportune that I just want to stress to everybody.
Yeah, no, I love it. Thank you so much for being part of the conversation today. Have a great day, everybody.
Thank you.
Bye.